All right, so we're going to start with overall view of abdomen. Okay. This one is a lot because there's so many organs that are going on in there. So when people come in with abdominal pain, it could literally be anything. I mean, I've diagnosed anything from pneumonia to appendicitis to kidney stones. I mean, there's so much in that one area that it requires a huge amount of health assessments. You can narrow it down because there's probably 500 diseases from the abdomen, because even you got to think too, when it's a female, it could also be reproductive organs because they're also in the abdomen, right? So this can just be very challenging. All right, so as far as HPI, which is
history of present illness,
we're going to ask about abdominal pain. Always ask where it's located. That will at least give you an idea. But remember too, in abdomen they can have referred pain, so that makes it challenging too. Okay. So like for instance, when kids come in with appendicitis, they don't get right lower quadrant pain, they get paraumbilical pain.
Okay.
So don't let that fool you either. Okay. A lot of the times when people come in complaining of abdominal pain, it's constipation. But that I feel like is kind of a lazy diagnosis. You really need to rule out everything else. Okay. All right. Do they have indigestion? So I want to see, like, is this a GERD thing, right? And some people that have stomach issues, because your stomach is up here, people don't realize that. They think it's down here. Your stomach is up here. So some people may come in complaining of chest pain, but it's actually a stomach issue, like gastritis or something.
Okay.
All right. Nausea and vomiting, always a given. Diarrhea, constipation, incontinence, of course, because I need to know if you're incontinent of bladder or bowel or both. And sometimes people can be having accidents for bowel, and it actually is constipation because the liquid stool is going around that hard impacted. So just because somebody's having a liquid stool does not rule out constipation. Okay. So basically nothing rules out anything. Good luck diagnosing abdominal pain. I think this is probably the most challenging thing to diagnose is when somebody comes in with abdominal pain, just because the differentials are endless. Like you'll see, I didn't even put differentials on here because it could literally be anything. Okay. And you got to realize too, the bottom of the lungs, right, goes down to right here. So some people will complain of abdominal pain, but it's actually pneumonia, you know. All right, jaundice. Why am I asking about jaundice?
Because they're like yellow.
But why am I asking for abdominal, I guess? Oh, yes. Okay. So if they have a liver disorder, hepatitis, cirrhosis, something like that, it may present. Oh, but pancreas presents that way too. Yeah. Pancreatitis. Sometimes gallbladder disease can present with jaundice. So just because they're jaundice does not mean it's necessarily a liver disease. Okay. Dysuria. Why am I asking about what is dysuria?
Dysuria is the pain.
Pain with urination. And what kind of disease processes would that?
It can be like UTI.
Usually it's UTI, and usually it's a cystitis, which is the bladder infection. Okay. Are they having urinary frequency? Now that could be lots of different things too.
It could be like diabetes.
It could be diabetes. It could be UTI. It could be menopause because sometimes they can't hold their urine very well and they'll have more frequency. Urinary frequency can also happen in prostate issues in men. So that doesn't rule out anything either. Okay. Hematuria. What's hematuria?
Blood.
All right. So blood in the urine, which could also be a lot of different things like UTI, pyelonephritis, kidney stones, bladder cancer. That doesn't rule out anything either. Okay. All right. PMH is
past medical history.
All right. So I need to know if they've had hepatitis, which is
for the liver.
What? Why the liver?
Oh, like
what's itis?
Itis, inflammation.
All right. So hepatitis is just inflammation of the liver, or cirrhosis. What is cirrhosis?
Cirrhosis is like the heart.
Kind of. Yeah. It becomes fibrotic because of what? Number one cause of cirrhosis, alcohol use. Okay, chronic alcohol use. Have you had any surgeries? That's always going to be in PMH, so I'm just going to skip that from now on because you always want to know if they've had a surgery on something. But let me note this for the abdomen. Anytime somebody's had surgery on anywhere in the abdomen, it is very susceptible to getting adhesions. Okay, and adhesions are when the scar tissue actually attaches to the muscle of the abdomen. And so, because they have to cut you all the way through, right? They have to cut through the sub-Q layer and the fat layer and the muscle layer and all that to get down to your internal organs in the abdomen. So when it heals, sometimes that scar tissue heals all the way to the muscle. So when people turn, it causes excruciating pain and you really can't fix it. Because the way to fix it would be to go back into surgery and cut it, but then you could cause more adhesions. So you always want to think about bowel adhesions if they've had previous surgery before and they're having abdominal pain with movement. Okay. Have you had any blood transfusions? Why do I want to know that for abdomen? What are they at risk of? What disease?
HIV?
Yes, but that doesn't have to do with abdomen.
Oh.
We've already talked about it. It's in past medical history. Hepatitis.
Oh,
Because you got to think it's bloodborne things,
Okay.
right? Because if you're getting blood from somebody else, I mean, now we screen,
Yeah.
but prior to a certain year, I can't remember what it is, 1980 something. They didn't screen blood. They just like took it from people and gave it to other people. And so a lot of people are getting HIV, hepatitis, other bloodborne illnesses, but you still want to know if they've had one. Why do I want to know about immunizations?
Immunization.
What immunizations have to do with the abdomen? There's only one, and it's a pediatric one.
Oh.
It's live, and it's the only oral one. And it starts with an R. And it ends with otavirus.
I was about to say rotavirus.
Okay, rotavirus. Very good, very good. All right, what are polyps?
Are polyps like the little...
Yeah, they're like little growths. They're not cancerous, but they are precancerous. So usually if they go in there with colonoscopy, you'd want to get those cut out because if you leave them, they're going to develop into colon cancer at some point.
Okay.
And then, of course, we're going to ask about colon cancer, right? Because once you've had it once, you're at risk of having it again. Why am I asking about STDs?
Because it's with the abdomen.
Yeah, so it can cause pelvic pain, like pelvic inflammatory disease, chlamydia, gonorrhea can cause pelvic pain, okay? One of the biggest questions you want to ask is a change in bowel habits. What is that a red flag symptom for? It is the number one symptom of this that we've already talked about. It's in PMH as well.
Colon cancer?
Yes, that is the number one sign and symptom of colon cancer is a change in bowel habits. You always want to ask. Not everybody gets constipation. Not everybody gets diarrhea. It's just this is very different than your norm. Okay. All right. For family history, we of course want to ask about any cancers, colon or rectal. And then any gallbladder or kidney disease, because that's in the abdomen, right? Mm-hmm. And a lot of kidney disease is genetic or familial, and gallbladder disease tends to run in the family as well. What is malabsorption?
Like not getting nutrients?
They're not absorbing it in the gut. There's something wrong with the gut to where they're not absorbing it. Again, that can be familial. What is Hirschsprung's disease?
I've heard it did.
Mm-hmm. It's a pediatric thing.
Oh, is that the one where, like at the bottom of the rectum?
Mm-hmm. Yeah, so at the bottom of the rectum, they are born without ganglion. So there's no nerve cells in the rectum, so they do not feel the urge to go to the bathroom at all. So in that kid, remember, they don't have meconium, so they won't pass their first sticky, tarry stool, and they will have massive constipation because that stool will just keep growing and growing, and they don't feel the urge to go. We have to cut it, remember, and then retie it together because that ganglion's not going to grow back. Personal history. Why do I want to know about their nutrition?
Like, are they eating greasy foods?
Okay, because that could cause greasy foods could cause gallbladder issues. Mm-hmm. Okay, what else?
I think like getting the right nutrients.
Okay, so getting the right nutrients is important. I want to make sure that what if their diet is super healthy but they're losing weight? I want to find out what's going on with that. Are you having a malabsorption issue? Mm-hmm. You want to ask about last menstrual period for females, of course. Okay, because a lot of times girls will come in with abdominal pain, severe, 10 out of 10. And then a baby pops out. So you want to make sure that you ask about last menstrual period because sometimes people don't know they're pregnant. Alcohol, stress, drugs, tobacco is always going to be part of past medical history. All of those can be irritants to the GI system, especially cigarette smoking and alcohol. Remember, alcohol can cause esophageal varices, where they get those big tortuous vessels in the esophagus. It can cause massive gastritis, right? So we want to know about that. All right, as far as PD history, things you want to ask about is gestational age and birth weight. Why do I want to know? What is gestational age?
Is that like how many weeks?
Yes, how many weeks? So after the baby is born, they will do a gestational age assessment and determine based on baby's development at that time what their gestational age is or how many weeks mom was in utero. Mm-hmm. And then birth weight, because I need to know, are we gaining weight? Are we losing weight? Now remember, it's normal for babies to lose 10% of their birth weight, but they need to be back to birth weight by 2 weeks of age. Okay. I want to ask about meconium passage. What do we say meconium was?
The first tarry stool.
That first tarry nasty stool, which has to be passed within the first 24 hours. Was your baby jaundice? Now, it's very normal for some babies to be jaundice, and there's bunches of different kinds of jaundice, so it is normal, but I do need to know, and I need to see how long it's lasted, okay? Did they have a history of GERD? Because GERD can cause permanent inflammatory changes here, right? So I'm going to make sure that I've asked about that, too. Do they have vomiting, diarrhea? Are they colicky? What's a colicky baby?
That's the ones that are like always crying.
They scream and scream for more than 3 hours, more than 3 days a week for a long time. Okay. Steatorrhea. What is steatorrhea?
Is that like the... I know it's with poop.
Yes, it's with poop because urea always means leaking.
Is that the way, like, the type it is?
Mm-hmm. It's what it looks like.
It's like the jelly?
No, that's current jelly stool. Mm-hmm. Steatorrhea is fatty, frothy stool. So you will see that in malabsorption. You'll also see it in people with gallbladder disease because they can't. The bile in the gallbladder is what helps to emulsify the fats. So if your gallbladder is not working correctly, you can't emulsify the fats in your guts. You just poop the fat straight out, and it will literally float in the toilet. It looks like fat. Okay. What is FTT? Remember, it's PD, so failure.
Oh, failure to thrive?
Failure to thrive. And in that kid, it means that they are less than what percentage on the growth curve? 5. Less than 5th% for the weight on the growth curve. I want to ask if a kid has lost weight. It is not normal for kids to lose weight. It just isn't ever normal. Okay. So I always want to ask about that. Are they constipated? Are there major stressors at home? Stressors at home can cause a kid not to eat well, which can cause weight loss. Well, we need to fix it, right? And then what's their diet like? Now, this is a little challenging because kids are picky eaters. So I never judge a parent for the diet, okay? Did I tell you when I took Amy to GI and they asked for a 24-hour diet recall and she told them all she ate was Oreos and marshmallows for breakfast, and that was probably true, and I was so embarrassed. The resident was the one that was asking questions. She was like, I don't think that that's what we're asking. I don't think that that's what you ate. And I'm like, no, she ate that. And then she looked at me like, whatever. She's weighed like 1 pound since she was born, so I'll let her eat whatever she wants, okay? All right. Let's talk about the order that we're going to do the abdominal assessment, because remember, it's different than everything else, right? So we inspect first, then auscultate, then percuss, last is palpate, because if you start poking around on that belly, you're going to cause bowel sounds that weren't going to be there before. So I want to hear what it actually looks like before. So let's go over to the right side where now we'll talk about each of the sections. So you're going to, of course, lay them supine. Now, some people that's uncomfortable for, and remember, pregnant people, you can never lay supine. Okay. If you lay them flat, then you have to put something underneath their hip, or they can get something called superior vena cava syndrome because they've got a lot of weight here. If you lay them completely flat, it will compress their superior vena cava and they'll get real lightheaded and real dizzy and they can pass out on you. So if you need to lay a pregnant woman flat, which you can do, but you always have to put a roll underneath her hip so she's kind of turned to the side. Okay. So when we're inspecting, we're looking at the skin. What does the skin look like? Now, with cirrhosis, they can get those big tortuous veins. Okay. So I want to look for that on the abdomen. What's the contour, which means what's the shape? Okay. Now, ideally, we'd like it soft and flat, but we live in America and nobody has a soft, flat abdomen. Okay. So, but you do want to document what it looks like. You can say soft and round if they have a rounder belly, but there's nothing wrong with it. Now, if you say it's distended, then that means it's firm to the touch and it's filled with air or fluid. So don't say that unless you mean it, because you have to do something about it, right? All right. Are there any masses? Are there any hernias? Now, hernias, you can see 2 spots on the abdomen. You've got this one, which is called starts with an H. Hiatal. Hiatal hernia. And then you've got one around the umbilicus, which would be a paraumbilical hernia. And a hernia is when the intestines protrude through the muscular layer. Okay. Diastasis recti. Do you know what that is?
I feel like I've heard it before.
Yeah, it's talked about a lot, but it's a pregnant thing. Okay. So when you're pregnant and your belly starts to grow, you have abdominal muscles that go straight down here, right? That's how people get a 6-pack. I mean, I don't have one, I wouldn't know. But I've seen one before. Okay. But when you're pregnant, your belly grows so much, it actually separates those muscles. And for some people, they don't go back to normal. So you can actually palpate an entire space between their muscles. It's very painful. They're more likely to get hernias. And it does require physical therapy to get it back. Okay. All right. Now we're going to auscultate and listen. For abdomen, you have to listen in all 4 quadrants, right? Okay. You are going to also auscultate for a venous hum. A venous hum. What's a venous hum?
Is it like the way it sounds?
Yes, and you'll hear that in the vein. Sometimes it might be normal, but it's almost like a bruit, so it needs some more assessment. Okay. And you may see that epigastric, which is way up here, right? Or umbilical. And what vessel will you hear the is the abdominal aorta. Yes, because the aorta goes around this way and then it comes straight down the middle. And that's why sometimes you can feel your heart beating in your stomach when you lay down flat. Okay. All right. We're going to listen for bruits. What is a bruit?
A bruit is like a hum too.
Yeah, it's like a turbulent blood flow. So it's a murmur of anywhere in the body except for the heart. And a murmur is turbulent blood flow. So if you hear a whoosh, 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 right? In the heart, it's called a murmur. Okay. If you hear it in any other vessel, it's called a bruit. And you listen for the bubba bruit with the bubba bell. That always does vascular sounds a little bit better. Okay. So you're going to listen over the aorta. You're going to listen over the renal artery. And you're going to listen over the femoral artery right on the panty line. Okay. All right. And then we're going to start percussing, which I don't see people do anymore. The only time I ever really use this is if I'm looking for liver size, because... or sometimes gas, like it should sound kind of dullish when you're over an organ, like a big organ. Like the liver is going to be dull because it's a dense tissue, okay? And you're looking for, you're percussing like this, right? Or I use my stethoscope, actually. I put my finger like this, and you're listening for different sounds. In the abdomen, you should hear mostly kind of hollowish noises if there's nothing in there. If they're super impacted or constipated, then you're going to hear dull everywhere because it's full of poop. Yeah. But mostly it should be empty, so you can hear like the duh, 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 duh. But then when it's over the liver, you're like... and then you measure out where the liver is, and you can tell exactly where it's at. Okay, so the liver should be, and this is often testable, 2.5 to 4.5 inches is how big the liver should be. So you're looking and kind of underneath this side. Now where the rib is, it shouldn't go very far past the rib. But if you're getting dull percussion all the way down here, then their liver is enlarged. They have hepatomegaly. Okay. You can also try to percuss the spleen, but you really shouldn't be able to palpate or percuss the spleen because it's in the left upper quadrant, which is protected by your ribs. If you can palpate or percuss the spleen, you have splenomegaly, big spleen, okay? You can percuss the kidneys as well, which are going to be dull, okay? I don't usually do that. I don't find it very, it doesn't give me a lot of information, but you can do it, and it would sound dull. All right, now we're going to palpate. So when you do that, you can either lay them supine, or if they're uncomfortable, because some people have other medical conditions where they cannot lay flat. It makes them uncomfortable. You can put their knees up a little bit, right? So they're just laying kind of like this. Okay. Just to make them more comfortable, you can flex the knees. So you start with light palpation, okay? And you're going to kind of feel over and say, I want you to tell me if this hurts. Does it hurt when I push down? Does it hurt when I let go? Because I need to see if it's rebound or if it's actual like organ pain, okay? And then you'll go deeper. You can also use the bimanual technique where your hand goes around the back and then you can palpate the side. So I use that technique for the liver. So I'll push up right here and then I can palpate right here. Bimanual means two hands, right? You can also use it on this side for the spleen, okay? All right. Make sure before you start poking around on their belly that they go to the bathroom or they'll might pee on you, especially people that have bladder issues because you're poking. Yeah. You know what I mean? And that's so embarrassing. Like, no, let's have them empty their bladder first, okay? Okay. Red flag bowel sounds are things that you would need to do some more investigation, okay? Is if they have hyperactive bowel sounds, like it's going, okay? Now your stomach growling is different. This would be like down in the actual like bowel, not your stomach, right? It could be something like gastroenteritis, like you've got, an inflammation, or it could be an obstruction. Now what you see with an obstruction is it's got up until the obstruction, and then once you keep going across the abdomen, there's nothing. And we got a problem, right? Yeah. Okay, we got a problem. All right, decrease bowel sounds. Now, decreased bowel sounds you can get with peritonitis. Peritonitis is the number one red flag thing of the entire abdomen. What is peritonitis?
Peritonitis is the fluid.
What is itis?
Inflammation.
Inflammation. Where's the peritoneal cavity? Your abdominal cavity. And what's the red flag sign and symptom of peritonitis?
Rigid board.
Rigid board-like abdomen. If you ever see that, that is a giant red flag no matter who you are, okay? We can also see very decreased bowel sounds in a paralytic ileus. What's a paralytic ileus?
Paralytic ileus.
What's an ileum or ileus? That's part of the small intestine. Yeah, okay. And then paralytic, what does it mean to be paralyzed? Right. So this sometimes happens after surgery when someone has had anesthesia and you've completely basically numbed their entire body and put it to sleep. And then the patient wakes up, but their gut does not. No. You cannot feed somebody with paralytic ileus because then you've put food into their abdomen that is not moving. That food will just rot, get necrotic, and they're going to get enterocolitis. And then you have to cut out their bowel. So don't do that, okay? Yeah. All right, if you hear very high-pitched bowel sounds, that could be something like a friction rub where there's rubbing of the organs, okay? A harsh musical, dun, 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 dun. It doesn't go like that. It just is a very harsh noise, and it almost sounds like kind of higher pitch, but it's more like a... No, just kidding, it doesn't go like that. But that could be a bruit. What did we say a bruit was?
Murmur.
It's a murmur of the body, right? Turbulent blood flow. Soft, low pitched, but continuous. You shouldn't hear continuous bowel sounds, right? Bowel sounds are kind of right? But if it's continuous, then that is usually a venous hum. You're hearing the veins, not the bowels. Okay. All right, red flag abdominal signs. I made a page for each of them, so I'm gonna cover that in a bit. But you need to know these main signs: McBurney's, psoas, obturator, Markle, and rebound tenderness. All of those are signs you have to do for appendicitis. They usually love to test on appendicitis signs. It's on every medical exam. It's on every nursing exam. They just want you to know all of them. Okay. All right. Other red flag abdominal signs would be positive Murphy's sign. A positive Murphy's sign tells me you have gallbladder disease, and I'm going to cover these, how to do them. Okay. Cullen's or Turner's, that is pancreatitis. Okay. And then a positive Cares is a ruptured spleen. Now, ruptured spleen is a red flag emergency because that patient's going to bleed out in absolutely no time. Okay. And then the reflexes I'm going to go over as well on different pages. But you know what CVA tenderness is?
What is the CVA?
It's not a stroke, if that's what you're thinking.
No.
Oh, sorry. Costovertebral angle.
Okay. Isn't that like where it's like at a certain like
in the back? So you're going to take, because vertebral is your vertebrae,
yes, and
costo means rib. So where the vertebrae meets the bottom of the rib, it makes this angle. And then you hit on their back. That's where your kidneys are located. And if they're like, and they're screaming, they either have pyelonephritis or they have kidney stones. Okay. All right. Do we understand the basics of the abdomen?
Yes.
Okay.